bile duct stones, and over the subsequent couple of years, whether those patients needed more procedures. When you first glance at that graph, you might say, oh, well, most people are only having one procedure. That's pretty good going. But if we actually go on to the next slide, we can see that the vast the majority of patients, and in fact, 52% of patients having a first ERCP went on to have another ERCP for stones. And so as a result, over 50% of all the ERCPs done for stones are redos. And I think that that really focused our minds and made us think, well, why should that be? And you can see that patients, many of whom having more than one, went on to have several further procedures. And that must mean that we were failing to clear stones. And so that's what we want to talk about.
That's really interesting.
Why we failed to clear stones.
Really interesting data, George, because you can see that either we don't finish the job at the first ERCP, either we think we finished the job, but we haven't finished the job and you have retained stones. Either we did finish the job and we know we finished the job, but for some reason these patients have recurrent CBD stones, which brings them back to ERCP. So in all three cases, it's a burden for the patients.
Yeah, and I think that the argument, of course, may be, oh, well, yeah, but some of those, they just had a stent put in at the end of the procedure. The stones were out, but we put a stent in. Well, that's fine, and that may be clinically justified, but it's still another procedure for the patient. And clearly that's not the whole answer, because many of those patients were having further procedures. So let's just start with the first case, just to show very briefly. So here we go. This is a case we did a little while ago, and if people want to watch this, they can on the Gastro Learning site. But Mariana, do you look at that and say, oh my goodness, this is a difficult case?
Well, I would say that it's not an everyday case. It's not a single less than 10 millimeter stone, which is the ideal case to start with a trainee, for example. But I prefer this than some other scenarios that I'm sure that you're going to show afterwards, with a huge stone or an angulated CBD or other real difficult stone scenarios. Here, I think that it's really manageable. There are some things that you probably show that we have to take care of stone extraction, some important steps. But I think that this is, let's say, level 1.5.
Okay, yeah. Any mistakes that you see in dealing with these stones? What are common mistakes that people make?
A common mistake is if you try to extract them a bit greedily by trying to take all in one go. So yeah. If you use your balloon, this is, I think, a good choice for a balloon catheter extraction, because you have your guide wire in place and you can go repeatedly on the guide wire. You have to start by the distal part. So you have to take like one or two distally, and then, move yourself slowly, proximally, take your time and not be greedy.
Yeah. No, that's, we say that to our fellows, don't be greedy. Start with the bottom one. And, it is often that it's the most distal stone that is the one holding everything up. And we would often, in that sort of case, do a little small, you would do a sphincterostomy, of course, and we might even do a small little sphincteroplasty. And then those stones, that can be the most satisfying case of the day. And then, everybody thinks you're brilliant because you've removed 20 bile duct stones, but actually a case like that shouldn't be too difficult. Great. You mentioned balloon. You favor a balloon over a basket for a case like that? When do you use baskets, if much at all now?
Well, baskets, I think that are useful if you have this situation where you have a very large CBD, very dilated, and the stone kind of floats around, and you cannot, you have a stone that's, manageable. Maybe it's 12 millimeters or something like that. It can be manageable without crushing it. But you cannot really, the CBD is so large that you cannot really have your balloon being occluded over it.
The balloon just sort of goes past it.
So this could be also useful to use the basket catheter there. But as a first choice for trainees as well, we will prefer the balloon catheter, prefer its possibility to be threaded on the guide wire, and the facility to remove many stones.
And you know, there are wire guided baskets, but they're not necessarily that easy to use, and case like that, just being able to go up and down with a balloon over a wire is a real help, isn't it? Great. Let's move on to the next case, if we may. And this, in fact, coincidentally, is an MRCP from a case that we did just this week. So if we can show that, case. So this is a patient who had I think 2 or 3 ERCPs elsewhere without success. They had been able to get a stent in, but they hadn't been able to remove the stone. Just take us through your thought processes about why this stone can't be removed, and what your steps for removal would be for a case like this.
Well, first of all, it's big. It must be, I'd say, definitely more than 50 millimeters.
Yep.
And it's not your oval stone. It's kind of like a square, cubic. Yep. It's not your preferred shape. And then I suppose that, well, the CBD doesn't seem to have any distal stricture, but the opening doesn't seem to be very large. So it might be a little bit tight there distally, like in 5 millimeters distally. These are some of the issues I can see.
Do you ever, when I saw this, I just wondered as well whether that stone might be straddling quite a low inserting cystic duct. That's a common scenario that we see, in which stones perhaps that may not even be that big, but prove impossible to get out, conventionally. And in fact, they're just straddling the cystic duct, and you can't quite ever engage them. Okay.
Because when you try to bring them down, they just go inside the cystic duct.
Go sideways, and then exactly. Okay, great. Tell us about. There's been a lot of interest over the last, I suppose, 10, 15 years about large balloon sphincteroplasty. Is that something you use? Is it something you would consider here, and for a case like this?
Yeah, I think it's a very nice first step technique. It's easy to use. It's been shown to be relatively safe if you take some considerations, some safety considerations. I think it's also safe in it doesn't, you can start with this before referring your patient to a tertiary hospital. So I think it's a really good technique. Of course, you have to be careful with the diameter. It's been described from 20 millimeters to 20 millimeters, but you have to take into consideration if there is a downstream stricture, if it's also the CBD diameter. You've nicely exposed this, George, the ratio of the CBD, the proximal CBD diameter, thanks to the distal CBD diameter. You've talked about this, that this should be taken into consideration as well. So if your proximal CBD is 50 millimeters, and the distal part is thinner, you won't go for a 15, 80 millimeter balloon sphincteroplasty. And then you also have to be careful not to dilate your balloon next to the stone, because that also may be you might have perforation there, and also not to exceed balloon dilation. If your waist is you still see the waist after dilating to the full capacity of the balloon, you should not over dilate, because this is also, it means that there's some fibrosis and you might have perforation there. So There's some things taken into consideration.
Brilliant. No, and those are fantastic tips. And sphincterotomy, I mean, I certainly feel pretty strongly that all these patients should have a sphincterotomy prior to any balloon dilatation above sort of 8 or 10 millimeters. Is that your?
Yes, it's my feeling. I know there's some data with large balloon sphincteroplasty alone, and I would be really scared to do that.
Yeah, 100%. I couldn't agree more.
If the patient doesn't have any issues to do even a small sphincterotomy, I would do it. I don't see any issue why not doing it. And now, if there are issues relating to anticoagulation, antiaggregation, in this case, I would feel more safe just placing a stent, see what we can do. If there's cholangitis, I mean, you tackle the infectious situation, and then you can see what you can do with the anti-aggregation agents, and not start dilating with the big balloon, and you can still have bleeding in that case. But
I think I don't know what your practice is. I do feel that if you're going to be doing balloon sphincteroplasty, you probably don't need to obsess to do a completely full sphincterotomy. You can usually just do a small or a medium sphincterotomy. You don't have to be going right up to the duodenal wall.
Yeah. I mean, that's enough to open a bit the sphincter and to have a good sphincteroplasty. I mean, the sphincteroplasty will finish the job anyway. It might be redundant doing both, doing a full, which with the bleeding complications of both being added. So no, you don't have to do a full sphincterotomy in this case.
Yeah. And I mean, I don't know your feeling, but we talk a lot about cholangioscopy, directed lithotripsy, and obviously that's it can be exciting. But in terms of impact on patient care, in terms of stone disease, I think that the safe deployment of sphincteroplasty, large balloon sphincteroplasty, should have a huge effect on stone clearance rates. For these sorts of cases of a moderately large stone, a dilated bile duct, and I'm actually quite surprised how many patients are referred into us in a tertiary centre who haven't had a safe attempt at balloon sphincteroplasty, and quite often we do that, and then it's a straightforward procedure without needing it. I don't know if that's your experience.
I think it's a good first step. Yeah.
What about mechanical lithotripsy?
Well, this is weird that you've asked this question, because I would have just said that the large balloon sphincteroplasty has largely replaced mechanical lithotripsy, and also if you see the systemic reviews that patients that have a large balloon sphincteroplasty have a smaller requirement for mechanical lithotripsy. So it's still, I think that it can still be useful in some cases. If you have a downstream stricture, I think that's still an issue that you cannot resolve completely with large balloon sphincteroplasty. If you have a downstream stricture in the CBD, you're still limited on the diameter of the balloon. So mechanical lithotripsy could be a solution there. And you also have the salvage mechanical lithotripsy. This is when you have the impacted dormia baskets. So this is something that is a lifesaver if you cannot really get your dormia, the basket catheter. It's around the stone and you're blocked and you cannot get it out. This salvage system, you have to take, of course, the whole scope and the dormia out of the mouth of the patient. It's kind of like scary. But it can really get you out of a very difficult situation.
I'm always surprised how using the salvage lithotripsy, it doesn't seem to damage the ampulla as much as one would expect it would. You'd think it'd cause terrible damage, but and I think it's worth. I think the point you make, it is important that every unit has a salvage lithotripsy on the shelf, and that people know how to connect it.
Yes.
Because it's one of those situations you get in if you're stuck with a stone in a bile duct with a basket around it, that's a slightly stressful situation. I would completely agree that, when I started my training many years ago, we probably used the mechanical lithotripsy, I don't know, 5 times a week. Now I probably use it 3 times a year, really very rarely use it.
Yeah.
And I think that's largely, obviously cholangioscopy is one factor, but largely due to large balloon sphincteroplasty, I think.
Yeah, I think so,
that's really, and I think the point, just to go back to and re-emphasize your really important point, that when we're thinking about balloon sphincteroplasty, it is absolutely crucial to consider the diameter of the lower duct. We've over the years seen 1 or 2 disasters where people have seen an 18 millimeter stone in a 20 millimeter bile duct, but in fact there's a low stricture, and people think that they can do a 15 millimeter balloon sphincteroplasty when absolutely you can't. It's only the sphincter that one is dilating with that, not a low bile duct stricture.
Yeah, exactly.
That's really helpful. Maybe we move on to a couple of interesting scenarios. Maybe let's show the next little clip and talk about Mirizzi syndrome, which traditionally has been a surgical problem, hasn't it? We see a stone in the cystic duct, and historically at conventional ERCP, this has been an absolute nightmare to sort out.
Yeah.
Certainly in our practice, this is where we really find that cholangioscopy is making a huge difference. And the surgeons are happy for us to go for a cholangioscopic approach, because surgically these patients can be tricky, can't they?
Oh yes, it's very challenging for them as well. Yeah. These are the patients that we used to treat with ESWL at the time.
But in Brussels, you still you use quite a lot of ESWL.
You still use it, but less for biliary stones. As you said, with these techniques now, you can have good fragmentation in even a single session with laser or EHL, especially with laser. Seems to be more efficient and shorter duration.
And I think that we had a case, just a short while ago, in fact, of a patient who I think had 10 ERCPs, elsewhere, and in fact, 50 ERCPs were not going to remove this stone in the root of the cystic duct, and was a very quick 20-minute procedure with spyglass cholangioscopy and electrohydraulic lithotripsy. So I think Mirizzi syndrome is a really good indication for that. Let's move on to and if people want to watch the videos related to these cases, of course, they're on the Gastro Learning site. Let's move on to another scenario, which can be a real challenge. Stones above strictures. And I know that we were just alluding to that with the discussion about sphincteroplasty, but this case, what's your approach to this scenario? I hope the imaging is reasonably good. Quite a dilated mid-bile duct with some sizable stones, but a low bile duct stricture. What's your approach to this sort of case?
Well, here I would, I suppose it's maybe a chronic pancreatitis patient. Or
absolutely, I think so.
Yeah. So here I would probably go for maybe stenting. I would dilate, but I would be maybe 6 millimeter dilation, something very reasonable. And not in the idea of taking out all the stones. I will feel a bit how the balloon passes, but I would probably start by stenting, either plastic stents. I would put at least 2 to start with, and or maybe a fully covered one, depending a bit on the anatomy. to have some
Yeah.
kind of remodeling, some calibration of the stricture, and then come back and reschedule him in the patient in 3 months, and maybe 3 to 6 months, depending if it's a fully covered or plastic stent. If it's plastic stent, I would come back in 3 to 4 months, a bit earlier, just to be sure, and then see a bit how the anatomy has changed. If we can take out those stones. I will not start by trying to take everything out to obtain clearance.
Yeah, I completely agree, and I think a case like this really emphasizes the need to review the imaging prior to starting the case.
Yeah, definitely. Yeah.
We've all seen in our practice cases in which it was absolutely clear. In fact, it's an interesting question that I'm not sure anybody properly consents the patient having an ERCP for stones as to the probability of stone clearance. It's one of those areas where maybe we're a little bit vague. We say, we're doing the ERCP, you've got a stone, you're jaundiced, but do we reflect with the patient the chance of clearing the stones? Because I would suggest that if one has done an MRCP for a case like this, the chance of clearing the stones at a first sitting is, well, about as close to 0% as you could get. And yet maybe we don't review the imaging carefully enough beforehand, and maybe we don't discuss with the patient enough. Now, there's some good questions coming through, Mariana, and one is, you often don't quite know what you're dealing with or what you may find when you're doing a case, even if you do review the imaging as you should do beforehand. Do you think there needs to be a cholangioscope on the shelf before proceeding to ERCP in stone disease, or do you think that's not really necessary?
Well, as you said, reviewing the images beforehand, having a plan, an initial plan, is important. Well, it depends on how the procedure goes. I think that if you're dealing with these patients with stones, you have to have at least the box. Maybe not open it, but you have to have it somewhere on the shelf.
Yeah,
and it has to be part of your toolbox. So I think if you have a referral center, tertiary hospital dealing with difficult stones, you definitely have to have access to have a possibility of cholangioscopy, but also have access to laser and or EHL to do the intraductal lithotripsy. Because if you don't have that,
I think
you can just look at it, but you can't do anything.
Yeah, and I think that's right. And I think that surgeons doing laparotomies have to finish the job, don't they? They can't keep coming back. And I think there's a little bit of an element doing endoscopy in general and doing therapeutic ERCP where, we can come back again in 3 or 4 weeks and do it again, but it's still an intervention, another intervention for the patient. We're carrying, additional risk. And I sometimes, talking to Urban Alano from Sweden, who of course is a surgeon who does a lot of ERCP, he has a surgical mindset, and that is that you're there to remove the stones, and really you should have everything available to try and finish the job. And just saying, we've put a stent in and we'll bring you back for another go, without having all the facility in place to get the job done, at a limited number of procedures. I think that's something we really need to move towards. And I think that, our UK data, I think, slightly points towards that. There must be an awful lot of procedures being done in which, you keep the patient safe, you put a stent back in, but you're not really driving forward resolution of the problem.
That will also help in changing a bit reimbursement for these advanced techniques. For example, in Belgium, currently, we still don't have a reimbursement for using single-use colonoscope for
Yeah.
these techniques. So I think we're going to move at one point towards that. I mean, 15 years ago, we didn't have a booster for metal stents. So things are getting better.
Yeah. And I think that, it's something that, Wim Lehman and others have been looking at the health economic argument,
Yes.
and certainly, the financial impact of a patient having 2, 3, ERCPs is certainly not going to stack up compared with being able to do a definitive procedure with additional equipment such as cholangioscopy. And I think that, that has to be where, the argument goes, and the patient-centered, issues around multiple repeat procedures. We've only got a couple of minutes left. I just want to ask about stents. There will be cases. We're not today going to talk about it, complex intrahepatic stones, et cetera, but there will be patients who have difficult bile duct stones that you don't clear at a first sitting. What do you favor in terms of stent choice? We've spoken about remodeling low bile duct strictures, but just generally speaking, outside of that setting, the plastic stents that you would use after incomplete stone clearance. Do you have a policy?
Well, if the CBD is dilated, I would prefer the double pigtail stents, 207 French ones. I think that you have to have at least 2. It has been shown that more than one will help in this fragmenting, this friction, and finally having at least less stone load when you come back. So I put two double pigtail stents, 7 French if it's dilated enough. If not, I would put a straight stents.
Yeah.
But at least I'll try to put 2.
Yeah, we also tend to use double pigtail stents, although double pigtail stents are the simplest stent in the world to put into a nicely dilated bile duct, aren't they? Yeah. But they're not easy. They're not easy in a slightly narrowed, bile duct. Getting the pigtail to form is a real.
Yeah, it always seems to be like pointing in the bile duct wall.
Yeah, and aesthetically, you think you're going to get it to curl, and then it hooks into the left duct.
And it seems like
I'm sure it probably doesn't make any difference, but you just feel slightly aesthetically. It's unsatisfactory, isn't it? Unsatisfying. Listen, that is fantastic discussion, Mariana, and it's a huge privilege having your expertise. Just wanted to finish. We've discussed a lot of different approaches: sphincteroplasty, cholangioscopy, stenting, but we started off by looking at data from England, but I can bet you it will not be hugely different in Belgium. The Netherlands, data is quite similar. It's going to be the same everywhere. What would be your one step, if you like, that you think would improve our management of bile duct stones?
Well, if we start from the baseline, I think that to be sure that everything has been taken out, because this also involves all centers that do ERCP, not only tertiary centers. And it's having a good cholangiogram at the end, and be sure that you have all your intrahepatic ducts and you have a good radiological interpretation of this cholangiogram. I remember when I started, we had a dedicated technician that really turned the patient a bit around just to be sure we had everything, the emergence of cystic duct, and you have to put everything into your report. I think this is something that's priceless, to really be sure that everything is out and you've seen all your bile duct completely. And this can be done in step 1. Now, it's normal that if you refer a patient because you can't get it out, I think it's very good, safe practice to do whatever you think you can do, put a stent and send the patient for a referral. Then he's going to have at least 2 ERCPs. But if we start doing that already, I think that we might decrease the patients that will have retained or recurrent stones in the long run.
Yeah, great, fantastic, really useful advice. I mean, 50% of all the ERCPs we do are for stones. And I think that it's an area where we can really improve, patient care and patient outcomes. Listen, Marianne, it's been, as always, a huge pleasure, privilege having you with us. Thanks everybody for joining us. We haven't been able to answer all the questions. And there's a Gastro Learning Express that comes through every Thursday, and we'll continue to meet for these Gastro Learning live events the second Thursday of every month. But for now, if you haven't had the chance to catch this webinar, you can go back to view it and all the other teaching tips. So thanks ever so much for joining us. And Mariana,